from Microbe TV. This is Infectious Disease Puscast, episode 64, recorded on September 25, 2024. Hello, everyone. I am Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How you doing today, Daniel? It's very stormy where I am. So
I'm doing very well, but wearing my Prion Mad Cow bow tie. But David does our audio and video. I think post-production scrubbing, and we were commenting on how radiant you look today. We didn't know if it was the lighting or some great news you have to share with us.
I'll just take the compliment, I think. Well, now I'll just be pink for the rest of the show.
See, now your color's even better. That's great.
Yeah.
So we now know for the best YouTube viewing experience, embarrass Sara at the beginning of each program.
For just a little bit of color. Yeah. Well, I'll welcome everyone. Puscast is our review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
Okay, we have some fun, interesting articles this time, and I will start us off with the viral section. Remember to listen to TWIV, This Week in Virology. I actually have a pretty long one that's going to drop. It'll drop before this one, talking about another Cell paper about how the virus, and now when we say the virus, we're talking about SARS-CoV-2, emerged as a zoonosis. And so we'll be talking about some pretty really interesting, compelling data there. But the article Outcomes of Intravenous Immunoglobulin Treatment of Immunocompromised Patients with Viral Respiratory Infections was published in Annals of Allergy, Asthma, and Immunology. Here, the authors performed a retrospective cohort study on all patients hospitalized for a respiratory viral infection between 2011 and 2016 at 2 large academic centers, including data on age, gender, virus, species, immunosuppression type, and receipt of IVIG. Outcomes included death, hospital readmission, length of stay in the hospital, and the ICU. A total of 270 patient admissions were reviewed, and about a third, 35.6%, received IVIG. The average age was 40.6 years of age. 50% were female. 74% were transplant patients. The most common virus was rhinovirus, 50.7%. IVIG administered within 48 hours of hospitalization, an N of 229, was associated with a shorter ICU length of stay, great p-value there, a shorter hospital length of stay for patients hospitalized at least 2 days, another great p-value. No significant differences in readmission rates or death. So I don't know, Sara, is this something you've seen used much at your institutions?
I was just thinking about how I wonder if you had asked me what percentage of immunocompromised patients get IVIG. I don't know that I would have had a number in mind. I guess this one is saying that they had about a third of folks who did. And I don't know that I routinely give it, particularly if someone had something like rhino. Maybe if they had like really protracted disease or you're kind of stuck and you're trying everything. But yeah, I think it's interesting. I admit I have definitely given IVIG in situations that probably made me feel better than it actually did helping my patient. But yeah, I think it's interesting just to see how many people gave it. I mean, obviously, how useful it is always hard to tell. But maybe there's a signal that it's helpful.
Yeah, I mean, it's interesting here. We have over 200 patients getting it, so.
Yeah. And I have, I think, just one viral paper today. I pulled this one from JID, Comparative Emergence of Maribavir and Ganciclovir Resistance in a Randomized Phase 3 Clinical Trial for Treatment of Cytomegalovirus Infection. And I looked back, I had mentioned the Aurora trial a while back, which looked at efficacy and safety of maribavir versus valganciclovir for first CMV infection after hematopoietic stem cell transplant. This found, that paper, Aurora trial, found a CMV clearance rate at week 8 of 69.6% for maribavir versus 77.4% for valganciclovir. So in this paper that we're talking about, they took a look at 241 patients who received valganciclovir or maribavir for at least 21 days. And they found that drug resistance mutations in 24 or 10% of the maribavir recipients were found at anywhere from 35 to 125 days after starting therapy, but that median was 56 days. And that included 12 of the 14 patients who experienced a viral load rebound while on therapy. Ganciclovir resistance mutations were noted in 6 or 2.5% of recipients, and that time range was 66 to 110 days, or a median of 90 days. So to summarize that, after about 3 to 8 weeks of therapy, maribavir resistance emerged earlier and more frequently than ganciclovir resistance. This is a lower overall incidence for maribavir resistance that was reported in another phase 3 trial for refractory resistant CMV infection, where they had a number of about 26%. And I linked to that paper if people did want to go find that. I think there probably is some differences there, like the median viral load being higher and those patients having also host factors that contribute to failure as well. But I think this is interesting because clinically I feel like, or anecdotally, feel like we're seeing resistance showing up in these patients that we're putting on maribavir, and it, again, being maybe a little earlier or more frequent than we expected. So nice to have some reference for that at least.
All right, I've got the article Antibody Persistence and Safety of a Live Attenuated Chikungunya Virus Vaccine up to 2 years after single-dose administration in adults in the USA, a single-arm, multi-center phase 3b study published in The Lancet Infectious Diseases. In this single-arm, multi-center phase 3b study, they recruited participants from the precursor phase 3 trial from professional vaccine trial sites in the USA. Participants aged 18 years of age or older were eligible if they had completed the previous study and received this VLA 1553. So chikungunya virus specific neutralizing antibodies were evaluated at 28 days, 6 months, 1 year, and 2 years after vaccination. The primary outcome was the proportion of seroprotected participants at 1 and 2 years. After a single live attenuated VLA 1553, so this is the IXCHIK vaccination, the chikungunya virus neutralizing antibodies above the threshold considered to be protective persisted up to 2 years, and there were no long-term serious adverse events related to vaccination. So just little background here. The live attenuated chikungunya vaccine, VLA 1553, Valneva, Austria, Vienna, Austria, so it's from the Austrians, has been approved by the US FDA. We were actually just talking about this in clinic the other day with my colleague, Marilyn Fabry. This is the first vaccine against chikungunya disease to receive approval, which is critical as no antiviral therapies have been approved for this potentially chronic and debilitating mosquito-borne infection. All right, and moving us into bacterial, be sure to listen to This Week in Microbiology. The article, Determination of 30-Day Mortality of Pulmonary Legionellosis. Do co-infections matter? So just remember Legionnaires and Pontiac fever. This was published in Open Forum Infectious Disease, and here the authors retrospectively reviewed 64 cancer patients with pulmonary legionellosis. So 73% were Legionella pneumophila, And that's important, right? Because when we're using those urine antigen tests, right, you got to sort of, it's going to miss some. Nearly all the patients received Legionella active antibiotics, yet 30-day mortality was 23%. I mean, this can be a deadly disease. Independent predictors of 30-day mortality were hyponatremia, bilateral lung involvement, SOFA scores of 5 or higher. Lung co-infections were common. 31% of the time they had a co-infection. But with such a high mortality, this did not significantly increase mortality. So kind of a nice graphical abstract, right? Showing us a little bit about the demographics, the type of Legionella species, and some of the independent risk factors for 30-day mortality.
Yeah, I think a good reminder of how profound the mortality can be with Legionella. I think sometimes people maybe forget. I just had someone who had a very severe case, so it's fresh on my mind and looking up those numbers. And I
Yeah, I
realized, I don't know if
think
you guys can hear I forgot there's like a hurricane that's like coming up through the Gulf. So I don't know if you guys can hear, but there's like so much thunder and like rain outside. So
Oh, no, your
hopefully it'll
audio
set the
is, your
ambiance.
audio is very good and directional. So yeah, I worry with Legionella. Well, for a couple things. One is, recently they've been saying, oh, increased incidence of Legionella like in my local area.
Mm,
But, I think I've shared when I trained, there was one of the um, other ID docs, I'll say that, who, just basically was under the impression there was no Legionella, wasn't testing for it, and wasn't necessarily treating for it. I think
yeah.
that, if you realize it's here, if you test for it, you're going to actually start identifying it. And, the incidence goes up. Well, the incidence of times that we recognize and diagnose it goes up.
Yeah. Yeah. And then I have another actually transplant related paper. I don't think all of my papers this week are transplant related though. So for those who aren't transplant oriented, but this one is from the American Journal of Transplantation. Donor-derived Bartonellosis in solid organ transplant recipients from unhoused donors in Alberta. This paper described a cluster of donor-derived Bartonella quintana infections in solid organ transplant recipients that received an organ from an unhoused, unhoused deceased donors in Alberta, Canada. And so they tested, it looked like there were about 32 of these deceased donors that were identified as unhoused and had an IgG to Bartonella performed. 11 of those had either Bartonella henselae or both henselae and Quintana IgG positive. And there were 37 organs transplanted from those 11, what you would say donor positive for Bartonella. And then there was one who didn't have a serology sense of donor ? Of those, 19 of 37, 22% had a negative serology post-transplant and were asymptomatic. 8 of 37 or 32% did not have a follow-up serology or report of disease. And then 6 of the 37 or 16% of recipients developed Bartonellosis secondary to Quintana. And the attack rate that they calculated for clinical disease from a positive donor was 12.5%. So that math is slightly different because they were just using the donors with positive serology and clinically symptomatic disease. It looked like the main presentation were skin nodules or papules at a median of about 5.5 months. So a potentially under-recognized donor-derived infection and something to think about, particularly with a new rash. But it's hard because most places are not going to have a screening strategy for this in place. We're not typically getting Bartonella serologies. I think even if you could, having that serology available to you easily and quickly is also a separate issue. So I don't know how other people's centers are, but when I send Bartonella, it takes a long time to come back. So anyways, it's, I think, pretty interesting. I can't remember if we had pulled a case report or something similar on a Bartonella case before. And if we did, it probably was me.
I'm
And
sure it
then
was.
yeah, should have better memory. And then I have one other one that was from OFID. An opt-out emergency department screening intervention leads to major increases in diagnosis of syphilis.
This is a good one,
It's
Sarah.
so great. I love it. So after implementing an opt-out ED syphilis screening intervention at a large adult ED in Chicago, syphilis screening increased from 3.6% to 24.4% of encounters, so about a fourth of patients. And those numbers are like going from about 5,000 patients getting screened to 37,000, which I think is useful, like just to see that spectrum there. So presumed active syphilis infection diagnosis increased increased 288%. So from 161 patients, or 3% of the screened patients, to 624, or 1.7%. There was specifically an increase in screening among pregnant women, with 5.9% screened pre-intervention versus 50% screened after implementation. Diagnosis increased by 750%. So that was 2 cases pre-intervention and 15 cases identified afterwards. And they also found a significant effect on screening and diagnosis rates among racial and ethnic minorities. That I'm not really giving justice to all the components of these papers because I really want people to go read it. But in sum, a huge dramatic increase in screening and diagnosis, especially in pregnancy, which is awesome. Their number needed to screen to detect one infection needing treatment was only 75. So, very cool. Thinking about universal approach, not just to HIV, but to syphilis would be something excellent for us to consider. So, love this. Any other thoughts?
Yeah, I wonder how we get the message out. I mean, there's more syphilis right now in the U.S. than ever in history.
Yeah.
And I don't think people realize that. And so, this is just a great publication.
Yeah, it's awesome. Oh, and I did put a picture of figure 1 that we can put up. It basically has a really just nice visual representation of that percentage, and the bars. There's like a regular blue bar, but then the red-ish color representing the new proportion of screened patients that you can look at before and after intervention, which is also just a nice summary of that as well. All right. Oh, and I will take us to our fungal section. For this time, I have to point out that I realized today that I missed Fungal Disease Awareness Week, but it was September 16th to 20th, technically in our last 2-week window, so I guess I'm not totally late.
Who makes these things? Who decides?
I think it's through the CDC, and I'm sure there's some other partner organizations.
They need to do a better job of making us aware of the Awareness Week.
Well, I feel like we're the people, who should know and tell other
if we
people.
don't know about it, come on. Falling down. I mean, I could have I was wearing my fungal bow tie, so maybe on some level I was aware, but not consciously.
Yeah. I was sad at myself. I was like, oh, I should have picked more fungal articles just to celebrate. But I did pick a good one. This one I pulled from OFID, Bridging Echinocandin with Azole Antifungal Therapy on Prevention of Invasive Candidiasis Post-Lung Transplantation. This was a single-center retrospective study of lung transplant recipients with Candida in donor or recipient samples, either pre-op or within 6 weeks post-op of their transplant. And the authors found that echinocandin as a bridge while awaiting therapeutic azole, so ITRA or VORI in this case, awaiting those levels was not associated with decreased post-op invasive candidiasis in the lung transplant recipients. So they compared a bridged and unbridged cohort, with the bridged group receiving azole plus mica 100 milligrams IV for up to 2 weeks, or until the azoles were therapeutic or discharged, basically whichever one was sooner. And I think, just as an FYI, this institution uses a universal antifungal prophylaxis strategy that also includes nebulized amphotericin B. There were 117 patients, 68 in the unbridged and 49 in the bridged. None of the 68 patients in the unbridged group had proven or probable invasive candidiasis, while 5 of the 49 in the bridge group did. Some notes on that, though. Of the 102 patients who were not colonized by Candida species and thus did not get bridging. 3 of those patients had invasive candidiasis. So they're not really represented in those numbers, but I think is a valuable piece of information. And then, donor airway Candida colonization was not necessarily associated or, clearly the contributor to the invasive candidiasis in the recipient. So only one patient had the same species, so maybe donor-derived Candida, while the other ones had differing Candida species. So, it's hard. They may not even really be directly related. So we still don't know what's kind of the best combo and duration and way to do antifungal prophylaxis post-lung transplant. But I think this is helpful because it's kind of saying it probably doesn't make a difference if you add the micafungin. Not that I think there's a ton of drawbacks usually to having someone on mica most of the time. It still is probably an addition that maybe they don't need. And, I'm sure there's different camps on how strongly people feel about bridging with mica in general and azoles, but we won't get into that.
Okay. Well, then I'm very excited about the next 3 papers we're going to discuss. So the article, Early Introduction of Candida auris Detected by Wastewater Surveillance, Utah, USA, 2022-2023, published in Emerging Infectious Diseases. So here they monitored the influent of the only wastewater treatment plant in St. George, Utah, before and after the transfer of a C. auris positive patient into that community, right? So it makes sense, right? You want to measure the water before it goes through the treatment, right? So that's the affluent, and then or the influent, and then St. George, Utah. I don't know how many people are familiar with St. George, that down in the southern part of Utah. Now, they propose that wastewater surveillance could be a sufficiently sensitive strategy for early detection of C. auris before it is detected in clinical surveillance efforts. So in addition, they report improvements to the culture method that we originally used to recover C. auris isolates from wastewater and demonstrate the utility of organism isolation in providing high-quality genomic data for investigation. So this is a paper worth reading, and it's kind of interesting to see. So you see, they start doing the monitoring, the patient comes in, you can see the detection goes up afterwards. So it's really, I have to say, I'm very, bullish on wastewater surveillance. It almost gets back to that Legionella thing, right? Like if you know it's there, you're going to start looking, you're going to make the diagnosis, but how do you know it's there until you start making the diagnosis, until you start detecting it? And wastewater is great this way for, we've seen, with COVID, looking for the SARS-CoV-2, with Mpox, we've seen looking for the virus there, and C. auris. I mean, this is just, I think, great stuff. All right, parasitic. Be sure to listen to This Week in Parasitism. We have the article Toxoplasma gondii, infection of Alzheimer's disease mice reduces brain amyloid density globally and regionally, published in JID. All right, if I don't have you there. So here, these investigators injected mice with either toxoplasmosis or saline, and then analyzed the brains for levels of amyloid. They found that the T. gondii infected mice had decreased amyloid burden in the brain globally, as well as in the cortex and hippocampus and many daughter regions. The daughter regions showed reduced amyloid burden, including the prelimbic cortex, the visual cortex, and the retrosplenial cortex. The olfactory tubercle, I'm not really sure where that is, but a region known to have increased monocytes following T. gondii infection also showed reduced amyloid after infection. So I will go back to eating my meat tartare and plan to get a cat.
Can I tell a story? So I'm one of those people who sends emails to themselves to remind them about something that they're going to forget. And today I saw an email to myself and it just says cats. No, there's no other context. I sent it to myself and I have no memory of why I did it. So maybe it was just a premonition about how I should get a cat.
Okay. But it's really important. You don't want to change the litter box every day. You want to sort of let it sit for a while so that, there is a good,
Stew.
toxo exposure risk there.
Mm.
And you want to be messy and kind of aerosolize it if you can. Don't wash your hands afterwards like that Olympic swimmer. All right.
I'm just imagining the clip of you just in that one little section, like, yeah, this is what Dr. Griffin told me to do with taking care of my cat.
Yeah, it'll be on TikTok. All right. Miscellaneous. Now, this is really a fun one. This is the article, Effect of Social Distancing Caused by Heavy Snowfall on Seasonal Influenza Epidemic in a Local Region in Japan, published in the Pediatric Infectious Disease Journal. So here the investigators looked at the impact on elementary and junior high school students of school closure caused by heavy snowfall in the Northern Territory compared with those of the Southern Territory on influenza incidents during the 2017-2018 season in Japan. I'm actually thinking this would make a great high school, Intel project or something, right? Where you start looking at what's the impact upon, disease X, disease X could be COVID, it could be flu, it could be something else. So the territory epidemic curve rapidly declined following the heavy snowfall. The Southern Territory's curve was like the nationwide trend throughout. Weekly incidence rate ratios in schools for the Northern versus Southern Territories varied from 0.23 during heavy snowfall to 2.32, like a tenfold difference there, 4 weeks after the snowfall. Cumulative incidence ratio of the Northern to Southern Territories was 0.92. Now, school closure significantly reduced the incident rate to 0.41, so a 60% reduction. But then it's going to come right back up because everyone's going to go back there. But they conclude, based on this, that relatively large scale, simultaneous school closures and social distancing could temporarily suppress seasonal influenza epidemics. So maybe instead of just having snow days, we could have some flu days off from school.
Sounds good.
Right.
Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. And if you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong or at federalpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.